working or not. Say for example, if everything works, then that's fine. But even then, you wonder whether it could have worked better, right? I mean, if there's some interaction. But then when it doesn't work, then we really are stuck. Is it because the drug is not useful? Is it because we have taken some herbal thing? Then that is really the difficult thing, because you may have a very good medication, but because of this interaction, it doesn't have a good, then you say, okay, I'll stop and try other things. Then forever, in your case, you've rendered as a Velcade refractory patient, then you lose that. Again, this is what I say, you lose that treatment opportunity forever.
So in other words, finish the whole treatment, then whatever, how long duration of treatment, then you get to know, is it working for your body?
Usually the treatment like Velcade and so on, within 3 cycles, so 3 months we'll know whether it's going to work or not.
Any more questions?
Pharmacist, sorry, do you recommend dietitian? Do you recommend that we see a dietitian or diet?
What do you think, Dr. Mo?
So, but you see, I don't think the dietitian will be able to advise you on this kind of thing as well. But then generally, the dietitian can advise you on, what are the food that you should take for certain calorie, what's your daily calorie requirement, how to prepare your food, for transplantation or immunocompromised patient. But I think a lot of these things, we have to, kind of know our own body. For example, if you have diarrhea, then don't drink so much milk. Go and seek doctors' advice on what's the cause of diarrhea. Is it due to the medication that you're taking? Is it because of infection? Or what? And so I don't know necessarily that the dietitian will be helpful if you generally have issue about what would be a good diet for me while I'm undergoing. But if you are going to ask like very specific symptoms, then that is not so.
I phrased it wrong. Would you all give a list to patient from the dietitian that is free consult discuss, advise us what food is compatible and food when we are on the treatment?
Because basically a lot of supplements and herbs, right? There's still a lot of unknown data out there. So, as Prof. Chong say lah, daily intake, most of them are okay. Just don't take anything, too much of anything. Everything in moderation is fine. Yeah.
One thing I want to tell you was it will be very useful because when patients come to see us, they say that I've got a blood pressure medicine, don't know the name, and then we are left to guess. I got a diabetes medicine, don't know the name. So, I saw recently a patient whose daughter-in-law has done the most fabulous job having a beautiful diary. So much so that I took like 100 photos of that diary. I don't think I'll be able to put it into force. But, one thing you can help us doing is to have a little, list of medications that you're currently taking. And when it comes to pharmacists, they can tell you when to take them, how to optimize all these things. And that's one thing I think they can very well do. But we won't be able to tell you what the root of something contains. That's difficult. But if you all can have a list of or diary, normal textbook, a notebook will do. Just write down everything and what all's been taken what days, and you see it in a minute, and everything's beautiful.
Professor, I actually had...
Mike, sorry.
Okay.
I asked this question earlier a little with Dr. Satish. I'm referring to my mother's case. She was diagnosed when she was 70, given an initial treatment of Zometa and thalidomide and dexamethasone. She has actually responded well to the treatment. The M-band occasionally becomes visible, but for the most part it's been very well managed. Velcade, I hear a lot of discussion about Velcade. The secondary issue is my mother has severe osteoporosis, which she had even before the myeloma diagnosis. And the osteoporosis is the one that seems to be progressing quite badly now. So I'm just wondering what is available for a patient like my mom, primarily to contain this osteoporosis progression in, and considering she has myeloma.
Is your mom still currently on treatment or?
She is. She is.
What treatment is she on now? Still thalidomide, dexamethasone, and zolpidem?
That's right.
I don't think that we would necessarily do anything more than that, because the zolpidem itself should cover the osteoporosis. So, but you're saying that the osteoporosis is getting worse, is it?
It's still
worsening
progressing.
Despite the fact that, and you say worse based on bone marrow
The
density
last
scan?
bone marrow density scan, that's right.
Is she taking calcium?
Are you taking calcium? Yes. She said,
She said she is.
yeah, she's taking calcium.
I don't know, so she did do a lot more. I think this is,
Yeah.
she's on calcium, vitamin D, and taking the zolpidem.
Not vitamin D, I think.
Calcium with vitamin.
Oh, with vitamin D.
I think you've already seen the bone metabolism doctor, right? Dr. Manju.
Yes. She's been discharged.
Discharged, okay. I think, I mean, we can discuss with them again, but, Zometa is, or something like that regularly is a standard of care. Anyway, yeah.
And is it Zometa at 4 milligrams or 5 milligrams on an annual basis?
4 milligram monthly. Monthly.
Or 4 milligrams monthly for the osteoporosis as well?
Osteoporosis is not approved for osteoporosis. Zometa is approved for osteoporosis. The other drugs approved are different, and they are the ones which are not monthly given. Some of them are given once every 6 months. They, treatment and prevention.
Like Prolia.
Correct. Yeah, denosumab and even pamidronate is there, and oral medications are there. Zometa as such, I don't think, we've not come across osteoporosis. It's a different line altogether.
I see. Okay, thank you.
My father was recently diagnosed with myeloma about 5 months back, and this is myeloma with renal damage. So looking at all the talks on transplant, I was just wondering if a transplant would be an option for us. He's about 67, 68 years old.
Okay, so I did mention about that in my talk, but we certainly can transplant patient who has renal impairment. Okay, so that in itself is not an absolute exclusion. The only thing is that the melphalan that we give is excreted in the kidney. So if in patients with renal impairment, we have to reduce the dose of melphalan that we give to the patient. Nevertheless, we have done a number of cases before where the patients have renal impairment and the outcome has been successful. The only thing is that these patients do have a slightly higher complication rate. They may run into more issue with fluid balance during the transplant process. And we have experienced renal physicians, kidney doctors in the hospital that help us co-manage these patients. So some patients may even need occasional dialysis during the transplant process. So they are a bit more complicated. So it's not as straightforward as the thing that I listed now. It all depends also on how serious the renal damage is and the overall physical condition of the patient. Because very often if someone has got a kidney problem, it may also affect their heart and other organs. Then in that setting, it may not be so possible. But if someone is generally fit, but their kidney is affected due to myeloma, we can still transplant the patient who has that kind of problem. Because you mentioned that dad is 67, 68, so it's already above 65, and you need a good physiological 68 to do that. So it all depends on the overall, what your father's other comorbid conditions are.
So this even would be a necessity for a kidney transplant as well, in this case? Because I think the kidneys are quite...
This is your father's kidney is dialysis, now
yes, it's in dialysis.
68. Well, we have... Okay, this is also possible, okay, but I mean, your father is the age is maybe a bit too high. We have had a double kidney allogeneic transplant in an MDS patient, or myeloma patient, who has kidney failure and a bone marrow problem. So he had a brother sibling who donated the kidney as well as bone marrow to the patient. And the patient actually, number one, is cured of the blood problem and cured of the kidney problem. And in fact, it doesn't need any long-term immunosuppressant because the marrow, the blood that's being produced is from the same brother as well. So this kind of thing can be done, but it's, as you can imagine, it's even another level of complexity. And 68-year-old may be a bit difficult because we are talking about not this kind of transplant, it's a donor transplant, which usually our age cutoff is even lower than 65 because the kind of side effects is a lot more patient. So it may be a bit difficult, but I don't know.
It depends. In context of myeloma, if your kidneys are badly damaged and in dialysis dependent, we need to know whether it's because of myeloma or another condition which is causing the kidney damage in myeloma. There's a condition called amyloidosis. So a few things are behind this, and some of this all have bearing on what we do. So I think we need to know what is going on before transplant. I think in my experience when I was in Royal Free, there's a patient who had kidney transplant and bone marrow transplant for amyloid. Kidney transplant first, and then a high-dose melphalan for amyloid. But he was younger. Okay, so it's hard to say for every it has to be individual case. Yeah.
Thank you.
We have time for one more question. Okay, there's no burning question. We'd like to thank our panel and thank you all for your questions. Now let's have quiz 2, and if you have been attentive, this would be very easy.
接下来我们将进入到今天的第二个问答环节。如果您有注意听前面的讲座，那么这些问题将是非常简单的。
So the first question is, which chemotherapy regimen should not be used in patients who are transplant eligible?
Okay. Yeah.
The next question. Autologous stem cell transplant for multiple myeloma is feasible except for the following.
So many A's. Who deserve a prize? Yeah, maybe Helen, you are the first one.
Which of the following is true for autologous stem cell transplant for myeloma?
Raise hand first. Okay, that lady. What's the answer? D. Okay. Okay, correct. Lady in green.
Which is or are the common side effect or effects following myeloma treatment?
Raise hand first. Okay, Madam Musgati. A. Is that A? Oh no, wrong answer. Nobody deserves a prize. Okay, next one.
I can't even read the question now. No, I'm kidding.
Maybe the lady there? Yes, correct.
How many times have we organized the national myeloma?
Okay, that lady is the first one. In grey color. False. Yes, I know. This is Clara. No, second row. The lady in grey color. Yeah.
What is the slogan of the artwork?
Anybody knows?
I guess everybody wants a prize because nobody raised it.
I think that lady who raised the hand? Beside the lady in black. Where the black?
Black scout.
See?